Shalom, Hartford Healthcare's Tina Verona. Thank you for joining us for this live Facebook discussion. Well, it's a common condition affecting many people. We're talking about hernias. In fact, Hartford Hospital surgeons perform more than 1,000 procedures each year. I'm joined this evening by Dr. Chike Chukwumah, Director of Hartford Hospital's Hernia Center, and he's here with us tonight to answer your questions in how to better understand hernias. Thank you so much for being here.
Thank you for having me, Tina.
And you know, there is a lot to understand with hernias, and I think that this is a type of condition because it's so common that once people are diagnosed, they think, I think I'm okay with this as long as it doesn't bother me. Do you find that they're often underestimated, this condition?
Absolutely, and the cost of underestimating this condition is in the billions of dollars in terms of lost time and also sickness with these patients. In the past, the paradigm was that if it didn't bother you, didn't have to address it, because the ways to address it frequently involved a painful incision and a significant recovery time. And time off work as well. That has really changed, especially with the introduction of the minimally invasive platform using the laparoscope or the robot, because you use smaller incisions. Patients are in and out of the hospital the same day, as against in the past where you had to be admitted to the hospital a day before surgery, right, and you were discharged a day after surgery. So the impact is significantly different, and thus the way we address managing these conditions is not so much putting it off for when the worst will happen, but fixing it when it's simple.
Sure. And I think the important message here is that this is a condition that you can't ignore because it doesn't go away.
It does not. It will not fix itself. I've had patients ask me that, and I can assure them that the hernia does not fix itself. Because the hernias develop in areas of your body that are prone to weaknesses in terms of your umbilicus and your groin, and you use those parts of your body every single day. For instance, your abdomen, you use it over 2,000 times, and your groin over 900 times a day. The hernia gets bigger no matter what you do.
How does a hernia actually form?
A hernia is, like I said, it's formed in areas that are predisposed to it, but there has to be an inciting factor, which is typically some form of persistently raised intra-abdominal pressure. And a good example is if you had a profound coughing episode from bronchitis that lasted 2 or 3 weeks. You see that in smokers' cough, and the amount of pressure that places on an already weakened spot of your body causes the muscles and the tissue there to fall apart. The other ways you would see it would be in patients that have to strain chronically because they're constipated, or patients that have issues with urinating that have to strain, or patients that have what we call central obesity, because that places a lot of pressure on your abdomen and your groin. However, there is a genetic, or what we call a familial predisposition to it, because you also have a lot of people who have all these conditions and do not develop hernias. So essentially, if you're prone to hernias from a genetic predisposition standpoint, and you have any of these risk factors that I mentioned that would cause you to have persistently raised intra-abdominal pressure, chances you're going to get a hernia.
You're going to get a hernia. And so with that, here's a bullet point. What are some of the signs and the symptoms to look out for that you may have a hernia?
The most important one is some form of asymmetry. A lump, a bump, whatever you want to call it, it's not normal. A key aspect with the bump, where you can differentiate it from a muscular contusion, an insect bite, is that this bump is typically reducible, which means it goes and comes. It's affected by gravity, and you can manually reduce it. That's a key component to distinguish it from the swelling you get from a muscle injury.
Right.
It could be associated with pain, but more times than not, the pain is described as a dull ache rather than a sharp pain. Sharp pain is a protective mechanism. Is your body telling you something is really wrong?
Sure.
And if you have sharp pain, you want to get evaluated sooner than later.
You never want to ignore that.
Correct.
Are there stressors that aggravate a hernia in terms, because you hear sometimes people will complain that there's pain and sometimes there's not pain, the pain subsides. Are there stressors that really aggravate a hernia at points?
Yes, they are. And a lot of it depends on where the hernia is, how big the hole or the defect is, and what, if any, contents are in it. But the things that would stress a hernia would be activities which involve heavy lifting with torque, which is sideways movement or up and down movement, i.e., lifting a heavy weight and turning from side to side, which you would see if you were vacuuming, or putting a heavy weight above your head, or picking something from the floor with your back bent.
You would feel the pain.
You would feel it, because what those motions do is it closes the defect. So whatever is within the defect gets pinched. And so if what is within the defect gets pinched and it has nerve fibers, you're going to have significant amount of pain. If what is in it is your intestine, it's going to make you feel nauseous, and it may actually make you vomit.
We are talking to Dr. Chike Chukwumah. He is the director of the Hernia Center right here at Hartford Hospital. He's in fact going to be hosting a class next Thursday in South Windsor, October 28th. You do need to register for that class. It's called Understanding Hernias, but you can go to, you can call our call center at 1-855-HHC here to register for that very important class, and he'll of course be answering your questions, and he's also answering your questions tonight. So we encourage you to ask your questions right here on our Facebook page, and we'll do our best to get them answered. I want to talk about mesh. This is, there's been a lot of controversy about the mesh procedure, but in fact, this is the gold standard for treating hernias.
It absolutely is the gold standard, and the significant amount of research has been done that has shown that to be the case. Without the use of mesh in an elective setting, the chances that your hernia is going to come back is over 30%. And thus, there are certain situations where we would not use the mesh, but those are typically in emergent situations when you're concerned about infection. In an elective setting, the definitive repair requires a prosthetic, because you have to remember, like we discussed, these patients have a genetic predisposition to getting hernias, so their tissues are not as strong as they should be, and just pulling the tissue back together, you're depending on that same tissue to withhold the similar pressures that it already failed from. So the use of a mesh or a prosthetic is using a material which is stronger than your tissue to reinforce that repair, and that decreases the recurrence rate or the chances that your hernia comes back to anywhere between 1 to 5%. And so if you look at the recurrence rate of between 1 to 5% and over 30%, you would have to really justify why you would not use it. Now, there's a lot of controversy about the use of the mesh, but my thought process is that the mesh never hurt anybody on its own. It's how it was placed and who places it that are more important factors.
And I think, the experience is key here.
It is.
It's your surgeon. It's going to a hernia center like Hartford Hospital that specializes in hernias.
Right.
So I think experience is very critical here.
100%. The first one of the questions patients ask me is, what mesh do you use? And I tell them this mesh has been in use since 1958. And so it's understanding, the materials. And I don't use the same mesh for all surgeries, and understanding when you should use it, why you should use it, what patient factors you should consider. And an example is a patient that is immunosuppressed on steroids, on chemotherapy, that is diabetic. You have to tailor each patient individually, and that's what we do here. It's not one size fits all. It's patient-centric.
Penny has a question. She writes, I had 6 hernias operated on in May and still have pain. How long before I get rid of the pain and get my strength back? Thanks for asking that question, Penny.
Well, Typically, the recovery period involves an acute inflammatory period, which lasts anywhere from 3 weeks to 6 weeks, where you could have, depending on the complexity of your hernia, you could have sharp pain. Another 6 weeks for pain or dull sensations with torque-like movements or straining. So I would say after 3 months, if you're still having persistent pain, you should get evaluated, and I would recommend that for her.
Yeah, absolutely. And let's talk about recovery. Even though these procedures are performed minimally invasively, which is less risk of infection, quicker recovery, recovery is very important. And to take that 1 month and to really rest and let this heal.
Right. I think that is critical. And the most important part of elective hernia surgery is timing. You are out of the operating room in an hour and a half. You're home the same day. Several days afterwards, you're feeling back to your, in terms of a pain standpoint, you're feeling close to your baseline. However, you still have restrictions because you have to remember that the tissue that has just been repaired doesn't gain its maximum strength for actually up to 3 months. So the first month, however, it is in a very weakened state. And if you put a stress on it that it can't bear, it could mean your repair will fail. And that is one of the most important things that I hear from patients is, oh, I was told I could do everything. I was like, and I usually recommend that that should not be the case.
Sure. Okay. Looks like, let's see, we have a question from Ken. Do you repair peristernal hernia with an associated ventral hernia?
I can, and I have.
Okay.
The peristomal hernia is the most complicated hernia that we fix as herniologists, because you cannot close the hole where the ostomy is coming from. And so the techniques that you use to repair those, especially in the setting of a ventral hernia, would be considered complex. We can, and I have, repaired those both in an open and a minimally invasive fashion.
Yeah, and again, and it depends on the patient.
It does.
Whether what type of procedure you're going to use, what
Correct.
type of mesh you're going to use.
It does. It depends on whether the peristomal hernia is a patient that has an ostomy from bowel or has an ostomy from bladder cancer, where that is their urostomy or their ileal conduit. So those patients, we take into consideration the type of surgeries that they've had in the past, whether they have, like Ken mentioned, a concomitant ventral hernia, or whether the issue is just around the ostomy itself.
Great question, Ken. Thanks for asking that. Let's talk about the importance of hernias in terms of having it as an elective procedure versus emergent, which you don't want to wait for and you don't want to have.
I think it's critical, and it's the most important point to make, that the hernias, when they are simple, you typically only need to repair them once. And that's because the techniques and the materials we use are so advanced that the recurrence rates are in the 1%. When you come in emergently, you may not be able to obtain definitive repair, especially if you have other issues going on at the same time of the surgery that are making you very sick. Your organs may be failing. You may have an associated abdominal infection, which would preclude the use of mesh. So what that means, and I frequently tell patients that are in this situation, is that your hernia will be coming back. Because when you perform emergent surgery, the focus is on saving the patient's life, and fixing the hernia becomes secondary. Unfortunately, we do see, especially with hernias that people have watched over a long period of time, that they come in with these hernias emergently when they are in their 8th or 9th decade of life. And those patients do not do well with surgery, even in an elective setting, certainly not in an emergent setting.
Can an untreated hernia lead to other health issues?
It can. That is a great question. And we are seeing that more and more, especially health issues that have to do with breathing, because your abdominal wall is what is referred to as an accessory muscle of respiration. So if you have poor abdominal wall function, it can affect your breathing.
Oh, interesting. So I think the key takeaway message here is that if you're diagnosed with a hernia, don't let it go untreated.
No.
Get it treated electively versus emergently.
I think that you've wrapped it up in a nutshell. We have the techniques to address that electively, and the most important thing about elective repair is picking a time where the post-operative compliance will be something that would not be a hindrance to you from a personal, a professional, or an extracurricular standpoint. And usually people do very well.
Dr. Chukwumah, thank you so much for sharing your time and your expertise with us. Tonight we appreciate your questions, and if you have more questions or if you want to attend Dr. Chukwumah's class next Thursday, September 28th in South Windsor, just call the number on your screen, 1-855-HHC HERE, Understanding Hernias, that's the class, and register. It'll be a great class, and this has been wonderful information for our viewers tonight. And thank you, as always, for joining us, and we'll see you soon.